Well, Andy, let's go ahead and kick off the podcast, sir. You've been very gracious with your time. So I'm sitting with Andy Bonner, the CEO of HealthCare2U. How you doing, sir?
I'm doing great.
Awesome. We've already basically had a podcast worth of discussion, which is always fun, but it's nice to get to know you, sir. I appreciate you traveling up from Austin in the rain.
Yep.
You said it was pretty smooth travels, but everything good on that front?
Everything's great.
Awesome. Well, I'm glad to give you an excuse to come up to Dallas. Are you going to do any business while you're up here as well? Make a trip out of it?
I've got a few people I'm going to see up here, but
yeah.
Hound them, maybe knock on some doors. Mainly about you.
Mainly about me.
Mainly about
I appreciate that, man. Well, so today let's kind of set the stage for what we're going to discuss, and then we'll get your background, of course, and you have a very interesting personal story that I'd like to share. But we're going to talk DPC. Direct primary care. I personally told you that this is an area of interest of mine. I think the model is very interesting in terms of being able to impact not only claims for employers, but also the quality of care. Yeah. So I'd love to talk about that with you, sir, and get your expertise there. But why don't you tell me, let's go back a little bit. Your journey into the insurance world, I know, was a little bit different than most. So kind of give me some of your backstory and how you developed HealthCare2U as well.
Sure. So as we talked about before we came on here.
Yeah.
Almost 30 years, non-insurance or non-healthcare related in the BPO space. So
what is BPO? I heard you use that.
Business process outsourcing.
Okay.
So worked with some of the largest companies in America to improve their processes. Folks like British Petroleum, Intel Corporation, McDonald's Corporation, and companies like us, we walked in and improved their internal processes and delivered 20 to 30% type savings to those companies. So
and was that something how did you lean into that industry? How did you even discover? I know you mentioned Xerox and some other companies and names I recognize. How did you find this space as a career?
It was actually coming out of college.
Okay.
So when I went through the recruiting process at college, a lot of my friends, I went to Training University down in San Antonio, and a lot of my friends went to professional, degrees, whether it be attorneys or doctors or whatever it might be. And at the time, IBM and Xerox were considered the two companies that were like getting a master's in sales.
Oh, really?
They had really intense sales training processes, and so I was attracted to Xerox's sales professional.
So was this knocking on doors type sales with the businesses, or when you say a great training program, what were we doing?
When I first started, yes, it was every single door that was down the street, you had a zip code and you went and knocked on it and tried to sell wares.
Okay, yeah, and so that's going to test you pretty quickly, right? But you're going to develop thick skin, but you're probably going to develop the art of how to overcome the initial objection and the gatekeepers and all that stuff. So tell me some of the things that you learned on the job being a fresh out of college guy.
Oh, I guess it's there's a lot to be said for tenacity and for working hard. I mean, the way I always talk about my sales success, I was one of the few who had 11 consecutive President's Clubs at Xerox, which is very hard to do, especially as you move from one position to another to develop that rapport. So I'm able to mirror clients very quickly, understand who they are, talk to them. One of the sciences around spin selling is really trying to understand your client and then replicate what your client does, and then also try to deliver the most out of a sales call versus trying to just sell one thing. Okay. I was always able to get the maximum in an opportunity versus just a single.
So you didn't land and expand; you expanded right away, right? You didn't get that one thing in the door. Right. You went. So what do you think about your ability or the artfulness of being able to sell a lot in one sitting? What was it that you discovered that you had a knack for?
Just asking a lot of questions, understanding, listening. Sales is not about talking; it's really about listening. And so, if you develop that trait early on, you can gain a lot from what a client tells you. And if you'll pick up on those things, you can, hey, this would help that, or this product would help that, and then you start developing a need for it in your conversations with them, and then all of a sudden the client goes, yeah, that's something I might want to consider.
Well, that's funny. Yeah, my sales journey, I was about 10 years into a career that was not sales related before I got into sales and didn't have formal training. So interestingly enough, I had the initial impression that you were supposed to go deliver this killer presentation and talk the whole time and not miss a word. And, quickly I obviously pivoted and realized that was the incorrect way to go about it. But outside looking in, I thought a salesperson was very slick talking and very smooth and suave. And I realized, to your point, the ability to listen and actually truly hear somebody, not just wait for your turn to speak and listen and pick up on things and let them tell you their problems. I figured that out over time through trial and error, but I think it's such an important thing for young salespeople to understand. It's not about how fast or how great you talk. It's about how well you listen.
Right.
Yeah. And that's so great point. And I'm sure that's probably a big reason why you were 11 consecutive President's Clubs, which is impressive. But you said that was a 30-year career, which we don't have to go at every single stop, but I do want to hear some of the evolution. And then I do want you to share the story, obviously, that predicated you building HealthCare2U, if you don't mind. But give me a little bit more of your career and how you found insurance eventually.
Yeah. So, I mean, I guess, I moved from equipment sales into solution sales. So Xerox was one of the leaders in what's called Xerox Business Services, the business unit. I'm dating myself here, but
That's okay.
Back in the early 80s or mid 80s, they were one of the pioneers in that field. And really what that is not just providing equipment, but providing people, process, technology, everything to run copy centers, data centers, mailroom operations, and so forth for large conglomerates or, big companies. It really took off in the law firm arena where, lawyers didn't understand how to manage a back office, and they would hire companies to manage that back office for them because they were charging quite a bit for a copy. It cost you 25 cents or whatever it might be, bill charges to a client. So for them, it was something that they wanted to outsource.
Okay, well, that makes sense.
Yeah, and so that's where it really started, was or pioneering that for Xerox. I did that in South Texas. Then I formed my own company, sold it to Xerox, not sold it, but partnered with Xerox. A little technical, we won't go there, but essentially it's a partnership. I had my own company. I sold that to Icon Corporation, managed Texas, Louisiana for a period of time, same type of business.
Okay.
And then I went to work for Kinko's Corporation, starting a concept or developing a concept called near-site on-site, where we would take a Kinko's office, like you're familiar with, where you go, drop your copies off. But we would sync one inside of a corporation and do a T1 line connection to encrypt the information coming back to the production center, so we could do just-in-time production on site and do all the heavy lifting at the Kinko Center. And so that would downsize the equipment footprint, less people needed on site, all the heavy lifting done on the appropriate equipment, and we're able to deliver substantial savings.
So you actually helped develop that idea or that concept?
I developed that concept.
Wow.
And we grew that business unit to almost 60 million over 2 years.
Holy cow.
And then I followed my president that I reported to over to a company called Standard Register, and we did the same thing at Standard Register. And that's really where the start of my travels into healthcare and insurance started.
Well, I appreciate that, because I always find it interesting, and I ask people this question on pretty much every podcast: how'd you get into insurance? And most people, even including myself, it was an accident, or somebody recruited me, or, I had a friend that told me I should go work here, but there wasn't a lot of intentionality behind it. And it sounds like that's a similar case to you, right? You had a 30-year career in something completely different. Right. And then you had an event in your life, obviously, that started your, let's say, your awareness of maybe some of the brokenness of our system. So why don't you share that story, and I think that'll lead us into the DPC story after that.
Sure. So the company I worked for, Standard Register, was self-funded. Okay. And so like most Americans who work for large corporations today, they were a Fortune 500 company. We all had cards, insurance card, that we made our healthcare decisions with. Mm-hmm. And as you know, being in the industry, that's one of the downsides of it, is you give people the ability to go spend it wherever they want to spend it. And sometimes costs can spiral. So at the time, I did not have a primary care physician. I was on the road, left on Sundays, came back on Fridays. And just depending on how bad I felt in a given city, I would go to urgent care in that particular city. Okay. Well, I developed basically like a canker sore on my tongue, in the back of my tongue, and went to urgent care, and they gave me something to take, and they had a lab jacket on and some scribble on it, and a stethoscope wrapped around their neck, and I believed every word that came out of their mouth, no reason to question them, and took whatever they told me to take and went about my business. Well, the spot didn't go away. Mm-hmm. And I repeated that
How long was the course of this?
About 9 months.
9 months, and so you had multiple
times
diagnoses, or what would you call? What would you consider? Just
oh yeah, I mean everything from as we mentioned before. I mean the last one was you're biting your tongue at night. You don't know you're biting your tongue at night, and that's the cause of your sore because we can't figure out what else. I mean, I'd haul all the previous urgent care information with me to every appointment, and they basically say, hey, we tried everything, and this is what it must be.
Yeah.
And so the place I like to go least in life is a dentist chair. So I waited another 3 months, and so that was a total of 9 months. And, he immediately looked at it and said, doesn't look right to me. You need to go see an not an orthopedic, but oral surgeon friend of mine.
Yeah.
And at this time, I'd moved from Addison, Texas, down to San Antonio, and this guy was treated the Spurs organization basketball team. And so I had a lot of trust in him, made an appointment right away. He looked at it and immediately said, it needs to come out. It's been in your wrong part of your tongue, been there too long, it needs to come out.
Okay.
So I immediately scheduled an appointment with the guy, and he took out about a third of my tongue. And then the follow-up said, good news is we got it, bad news is you got cancer.
Yeah. So, man, that's a pretty, after that long of kind of misdiagnosis, I think is probably the appropriate label for that. Going around different urgent cares, going to a dentist,
right.
Like nobody can tell you what's going on. You said it wasn't physically painful though, right? At the time?
It was not physically painful. And as we mentioned before, when you get cancer, and I was treated at MD Anderson, thank God. I'm glad I got to MD Anderson. Because they specialize in different sections of the body. And so it was a head and neck arena at MD Anderson. They have a team of people that look at your diagnosis. They only do labs for head and neck. So you're not thrown into. So I went through everything from misdiagnosis on tissue size or sample size that would predicate different protocols and treatment or possible massization. And so it wasn't until I got to MD Anderson that I felt very comfortable. They're a conservative-minded organization, but did a follow-up surgery there. They did a further dissection, took out lymph nodes in my neck, and then I went through that process of doing the follow-ups. And generally, you follow up if you don't have any reoccurrence. It's about a 5-year process.
Yeah, you told me something about that cycle, the kind of the emotional cycle.
Sure.
That I think is pretty interesting for you to describe, because I'm sure somebody that's listening might have had a family member or themselves gone through this, but I haven't. So you were saying there's this almost this emotional cycle you go through when you're about to have a quarterly checkup where you're kind of preparing yourself for the worst news. So tell me about what that was like. Yeah,
it's just you withdraw from your family. You kind of go into a dark space. You're preparing yourself for another diagnosis.
Yeah.
But you relive it again. So you relive what happened. Why did that happen? And I was misdiagnosed for 9 months. And why did that happen to me? I had the wherewithal to go wherever I wanted to go. Mm-hmm. But I was going to urgent care. Mm-hmm. And so the more I kept analyzing it with my background, my BPO background, I'm a problem solver. That's what I did for my entire life for major corporations. So it kept just bothering me and bothering me and bothering me. And then the more it bothered me, the more I researched, the more I realized how big of a problem we have in the entry point of healthcare. And the more fascinated I got with it, and the more research I did. So it was kind of like a snowball effect, I guess.
Yeah.
And it happened over a period of 5 years. So it wasn't like just one day a light went off.
Yeah.
And I want to switch from BPO over to developing an entry point or direct primary care.
Yeah.
Didn't
didn't even know what the term direct primary care was at the time.
Had no clue what it was, quite frankly.
So other than the misdiagnosis and the frustration that probably surrounds that, was it things like not knowing where to go, navigation? What are the things that initially you thought, oh, that's broken about this process? What were the things, first impression or first blush, that you thought you might be able to help correct? This podcast is brought to you by True Captive Insurance, a premier medical stop-loss captive for employer groups ranging from 25 to 1,000 employees. True Captive believes in healthcare that is personal and insurance that isn't complicated. That's why they take a white glove approach, making it easy for employer groups to transition into a program built specifically for them. Check them out at truecaptive.com.
For me, people think that just because of the fact that you have a card doesn't mean you have health care.
Yep.
Right? Folks in your industry do a great job of providing health insurance, but that doesn't always result in health care.
Correct. Yeah.
And one, it takes a willingness, a participation. It's a participation game. One, You got to provide accessible healthcare.
Yeah.
That's affordable healthcare. And quality health care. And those three components are not always served well. So for me, I had a card, but I didn't know where to go. I had no experience in it.
What was your process to find a doctor at that time? Google it?
No, at that point, it was I'm in San Francisco, for 2 days on sales calls with my sales reps, and I want to go get this checked out. Yellow Pages or whatever.
Right. Yeah.
Let me go find the nearest urgent care. And went to go, dropped into an urgent care, presented my card, and off we went.
So how did this evolve, though, for you? When you started going, all right, I've had this personal experience, meaning you, Andy, had this personal experience. Was it the recognition that probably a lot more people have it as well? Like, when did you think there was an opportunity for you to build some sort of business around
Well,
it?
at first it was, I wanted to be involved in the cancer aspect of it.
Okay.
I realized very quickly in pretty short order that, being involved in the cancer and the diagnosis of cancer and the front end of cancer is very difficult, requires a ton of money. But the second deal I did was I wanted to be in healthcare. I knew that as I got through my journey about 3/4 of the way through. And I went to go work for a company called White Glove Health. I don't know if you're familiar with them.
I don't think I've heard of them. No.
They were out of Dallas, and they were one of the pioneers in the nurse practitioner to your home model.
Okay.
And I was in business development for that company, and that was the first time that I really had delved into the beast. I guess it's really sunk my teeth into the belly of the beast to understand what it was. And I thought that was a great concept, but what I realized from a financial aspect as I started to really look underneath the covers, financially it could never make sense because a nurse practitioner costs you so much money. They can only make so many calls a day. You got auto expense. You got
Logistics,
just all this stuff. So when I left White Glove Health, I was actually on a mission to replicate it but do it better. And so a couple of the execs and I who had left at this time, we were going to go and try to make the product better. And it was at that point that I realized that it was that the only way it could be successful if you didn't have utilization of the plan. If you had less than 30% utilization, the numbers worked. But once you got above 30, I think it was 32% utilization, it turned south, and the model actually lost money. And that was contrary to what I was trying to achieve. For me personally, it was always about trying to deliver care and wanting people to get care.
Yes,
it wasn't trying to restrict care.
The financial model, like you said, is sort of predicated on we don't want people to use it too often, right? And it's like, well, what about the care side, the care part of that equation where you're wanting people to go get care because you can catch things early, like in your situation, or preventative style care, or setting baselines, which we talked about earlier. Just knowing what the condition of is a person right now, proactively rather than reactively in an acute setting. It just seems interesting that model falls apart if utilization, like you said, was above 30%.
Right, and there's other people in that space today. I think Fetch and some other folks that are in that space today. And maybe
I think Nice Healthcare is one that I've talked to recently. They do some on-site stuff.
So they've made some improvements in the model. So my point of reference is that particular deal. But really the kind of the core. So I went there first, and then secondly was trying to develop my own centers. So create my own clinics. And so the first thing I needed to do was find a chief medical officer. And I think I tell a lot of people, for me, my journey's been a lot of divine intervention because I happened to be watching an early morning news program in the morning one day when I was sitting at home, and I saw an interview with a doctor, Dr. John Rodriguez down in San Antonio, who was doing this membership program down in San Antonio. And I looked at that and I go, that's exactly what I'm looking for. And I just took a flyer. I called the guy out of the blue and said, and I got him. And I said, would you like to have lunch? And so we went to have lunch, and I said, I was looking for a chief medical officer. I don't know what you're doing on the business development side, but that's been my 30, 25 at that time, plus years experience in that world, and maybe we could team up. And from that lunch, we developed our partnership.
No kidding, right? Just right from one lunch.
We developed our partnership, and we started by trying to raise several $1 million to build 5 clinics in San Antonio. And I'm reminded of the the song "Some of God's Greatest Gifts Are Unanswered Prayers."
Uh-huh.
I think it's a George Strait song, but that happened to us. Nobody gave us money, and so we had to try to figure out a different way to try to scale it.
Yeah.
And as I mentioned to you before, part of my background was developing this near-site on-site concept, and so I looked at that and I went, could that apply in the healthcare world?
Mm-hmm. Mm-hmm.
And at this time, we were running our company out of John's practice in San Antonio. So single office location, San Antonio, Texas. I was driving down every day from Austin.
Oh, wow. Yeah, that's a commute.
And so what we decided to do in order to figure out what we needed to do, we had to figure out what max utilization would be on a program. And not to get too technical, but there's protocols for treatment of diabetes, protocols for treatment of hypertension and so forth, AMA protocols.
Mm-hmm.
But what's really not understand, and it changes every year, is acute utilization. And we probably just experienced the most acute utilization in our history just the last 2 years, where offices were flooded. Not only were offices flooded, but a lot of your physician offices were closed. They didn't want to see patients in person. Mm-hmm. It was that's why telemedicine took such a jump. So it was trying to determine what max utilization was. And if I could figure out and determine what max utilization was, then I could develop how low of a cost I could make it to where everybody won. Because I didn't want it to go direct. Mm-hmm. I didn't want to sell direct. I wanted to sell through brokers. I understood that through my experience at White Glove Health.
Very smart. Yeah.
So I wanted to sell through brokers. And so in order to do that, I had to have something in there for the broker, make it advantageous to the business owner, most of all make it advantageous to the employee mm-hmm. and a practicing physician. And hopefully at the end of the day, there's a sliver left over for HealthCare2U.
Yeah, fair enough.
Right, so that's how we started. And from that point, once we figured that model out, then we just started marching. And as we developed interest, we would put clinics in different locations.
Okay. Well, so before we get too far, I do want to take a moment. If anybody's listening to this that doesn't know DPC, the terminology, I'm sure they do, but direct primary care, if you wouldn't mind in your own words, describe to me what that model technically means, broadly speaking, then we'll talk about your specific model.
Yeah, so broadly is it's obviously it's you're trying to provide very good care, but in a membership fee environment where there is no claims that hit a health plan.
Okay.
So it's a lot of people, our tagline is no claims healthcare. So everything that we do runs outside the plan, does not generate a claim against the plan. Mm-hmm. And so you pull all those claims off the health plan, and they're handled through the membership fee that either a member pays or an employer pays on behalf of the employee and their dependents or whatever. And that's the easiest. But it's if you think about it from a family care, internal medicine doc, or generally the folks who are involved in this type of practice, everything that happens in the four walls of a family care practice is what's included in that membership. Yep. And that can be pretty broad. Yeah. It can be everything from skin rashes to small laceration repair to, your annual physicals, your well women's exams, your basic labs and those types of things. And so when you start really putting the CPT codes to all those care items, mm-hmm. It amounts to quite a bit of the spend inside of healthcare, or what we consider about 85% of the needs of people in healthcare is provided underneath this type of membership.
85%?
85%.
Wow, that's phenomenal. So talk to me about the why, though. I want to understand the why that model juxtapose it versus the fee-for-service, right? What is the problem, in your opinion, with the fee-for-service model, and why does DPC correct some of those issues?
Well, I mean, the problem with this fee-for-service model, other than the fact that doctors generally lose in that game, mm-hmm. We talked a little bit before, the change from ICD-9 to ICD-10 really makes doctors have to be very good business people. And there's about 5 support people to one physician in a standard primary care single practitioner type office. Mm-hmm, mm-hmm. And so what that equates to is doctors are making about the same amount of money they were making 10 years ago, seeing substantially more patients. And so under fee for service, doctors are paid for time increments. And you hear it all the time, especially from the broker community, that time is, if you can't spend time with a patient, then you really can't grasp the total concerns or the total care needs of a patient. If you're only spending 6 minutes, there's no way you can possibly understand the complexities
it feels
of
like
the patient.
from a patient perspective, it feels like you're just on an assembly line and they're just churning you through the doors.
Now, what's interesting in modern day, I mean, you look at a doctor today, a doctor takes Aetna, they take Humana, they take Blue Cross, they take a whole bunch of different types of care. Even nowadays, or at least since I've started this practice, health shares have come onto the scene and become very popular.
Yep.
So doctors take those kind of programs. Different types of PPO networks they belong to. So they're used to practicing in different types and adjusting to different types of care models. So for us to understand that you really, to be successful in the kind of practice that we do, is not to upset that fee-for-service doctor as much as possible. You don't want to come in with a whole bunch of regulations and say you got to do this, and this. You want to care for the patient, go do what they went to med school for, but give them the time, pay them for that time in order to diagnose the patient correctly, and then care for that patient. And by doing that, you're allowing them to also do things like caring for diabetes, caring for hypertension, things that fee-for-service really doesn't pay a family care physician to do. That's why you see so many family care physicians, as soon as they do a lab draw on you and it comes out to be diabetes or you got high blood sugar or whatever, they're immediately sending you out to an endocrinologist for your care, because they're really not paid for or reimbursed for in the fee-for-service world to take care of that patient. And the more complex they are, certainly not, and so they send them off. In the primary care or the DPC world, we have the time to be able to care for that kind of patient. So that's why in our membership, we also, in addition to all the acute conditions, the annual physical, we also provide 13 different disease states that we care for, as long as they're within management ranges.
Yeah, and one of the things that, man, there's so many, I love this topic. So there's so many questions I want to ask you, but one of the things that I want to comment on the fee-for-service is, like, what I see it as from my perspective, and I'm on the outside, you're in the inside of this business, so I want you to weigh on it, but you have a quality of life component that's been extracted from both sides of the equation, especially for the doctors, right? So you said they're making about as much money as they made 10 years ago,
right?
But the stress level is up. They're taking in more patients. They have all the burden from running this business, all the administrative bloat that's required to work with insurance companies to get these claims paid. Those doctors are just, aren't they leaving kind of in droves as well?
Yeah,
like,
I mean, since the pandemic, they've been bought out.
Or they've been bought out. But I mean, like, if I'm a doctor that went to school for 10, 15 extra years, and I'm making the same money I did 10 years ago, but my stress level is up, I'm getting tired of doing it, I get burned out. Like, why would I want to continue down this path? I mean, a lot of them could probably leave and go do something else and make a similar living as well.
And they are. And I think that had a lot to do with why people did move into direct primary care.
Yeah.
I mean, the other piece that's really not well known is a bad debt that these doctors have to carry because of the fights they have with the blues of the world, or the bigs, as we call them in the industry. So, they're constantly having to manage cash flow. They're burnout because they're seeing, sometimes 30, 40, 50 patients a day.
This is crazy to me.
And so they have extenders. So they employed a lot of extenders. And so that's a lesser quality of care that your patients are potentially getting. And it's kind of what I experienced in the urgent care model, is that you're not always talking to a board certified physician. Lots of times you're talking to extenders who are providing that care for you.
So an extender would be like a nurse practitioner, correct? Yeah. So you're not necessarily even getting, like you said, the highest level of expertise, but the presumption, and you had that same assumption that I would have, if I go into urgent care, I'm talking to a doctor. In reality, you may or may not actually be, right? Or maybe even most urgent care settings are not actually board certified.
Yeah, I think a lot of times when that was my experience, prior to being in this business, is that, it's scribble.
Yeah.
And you can't tell the designation. And really for some reason, when someone puts on a lab coat and they put a stethoscope around their neck, you give them utmost trust.
Yeah.
And pretty much everybody does.
Why do you think I throw on the blazer? You're trying to have credibility just by throwing this blazer on. If they only knew, the people only knew.
Right.
So I do want to move into the HealthCare2U solution specifically,
Sure.
right? And one of the things that you told me over coffee that was intriguing to me is that your focus is a lot on efficiency as well. So talk to me how that model versus what I think you believe you called the truest model, which is really predicated on length of time that you spend with a patient and giving everything under the umbrella. You have this layer of efficiency that you guys like to add on. So talk to me about that. This podcast is sponsored by PlanSight. PlanSight is a technology for employee benefits brokers to more efficiently manage their RFP process for any group size, all funding types, and over 20 benefit lines and point solutions. PlanSight is the only end-to-end RFP technology on the market today. Let's modernize your RFP process together. Check us out at plansight.com.
So again, going back to my roots, when I look at a problem, I'm trying to solve the problem through technology, efficiency, fishbone, process flows, all those kinds of things. So when I looked at the issue associated with the entry point of healthcare, I noticed a couple of things. In the fee-for-service world, a lot of physicians have become cold providers, flu providers, acute conditions. And they run them through their practice every 6 minutes. And they have to lay eyeballs on somebody in order to generate a claim.
Yeah.
And that's what their practice has become. And anything that's complex, they jettison out to the specialist world. And the reason for that is because they're simple. It's a simple diagnosis, an antibiotic, whatever it might be. They're out the door. They get their 70, 80, whatever their reimbursement rate is, and they're gone. The direct primary care, the folks who began the industry were really focused on limited panel and spending max time with a member. And that's great, but in my opinion, I don't need to spend 30 to 45 minutes with somebody who has a cold. There's a better model and better technology out there to utilize to take care of that type of a patient. So we layer technology, we layer telemedicine or virtual, what we call virtual primary care on top of our clinics to where we can pull out the simple acute issues and take care of those through a more appropriate type of a method and much more acceptable method in the industry today than when we started 9 years ago.
Oh, yeah.
Mind you, especially during the pandemic.
Yeah.
It's been much more widely accepted. And now you see a lot of people, virtual primary care is a way to scale because the traditional direct primary care, the single doc clinic, 600 patients is so hard to scale.
Yeah.
So what we've done is we've layered that. We still pay a physician to practice with us for that patient, but in lots of times where their time is spent is in dealing with a disease state or the annual physical. That's where the long period of time is spent with that patient.
I see.
Versus every single time allocating 30 to 45 minutes with that patient.
When that almost unnecessarily, right? It's like you feel an obligation to fill that time with that patient when they might not need it if it's something acute. Correct?
Yeah, and so what it allows you to do, and listen, I take nothing away from the folks who are doing it the other way. I think both models are great models. I think what I've been able to do, or my company's been able to do, is we've figured out how you can scale. So today we're blessed to have members in all 50 states. We operate in all 50 states. We have operations in all 50 states. And we're able to do that and stay out of the DOI and stay out of any issues associated with the corporate practice of medicine because of our structure, the way in which we do our accounting, and then also our relationship with the physicians and our partners. We scrutinize and we ensure that they're board certified in every state. They go through a 47-page credentialing process. They actually sign a partnership agreement. All of our providers do. And so we've created, since 2013 is when we started, a very robust, what we call a private physician network. It's a network that we own. So from a proprietary standpoint, it's ours. And then we've put technology into place to where we're holding, not only are we making it easier for the doctors to practice with us, but we're making it easier, what I call solving for Andy, what I went through.
Yeah.
Our members don't have to go through. They remember one number, or they press one button on the app. That gets them to HealthCare2U. And then from that point, we hold their hand and we do everything from that point on. They never call a doctor's office. We schedule all appointments. We do everything.
Yeah.
And so that navigation front end is key to making it work. And then obviously the relationship with doctors and making it easy for them to practice.
Yeah, I was going to say, one of the things that you said that I like is that you've layered on an additional level of efficiency in the model that you described, right? So like if we think about just the standalone clinic with 600 patients that are required in order to stand up that clinic and make it profitable, at least they're bucketing out all of those services that would fall under the umbrella. So if I'm an employer, I now have a fixed cost line item that's associated with this. And if it is 80 to 85% of claims or whatever that number is, they're now in this bucket over here, and I don't have to worry about the variable cost.
Right.
You're layering in, like from what I'm hearing, the things that can be handled through telehealth or virtual primary care. So you almost take this bucket that got put over here, and then you have a drawer that you pull out, and you put the stuff that could go virtual in. So the efficiency's gained again. There's like a second step in the efficiency that you've created by putting those things that can be handled over the phone. Very simple. You're saving the patient time and effort. You're saving the physician time and effort, and the plan benefit. So I really like what you described there. The other thing that I think you were going to get into, and I wanted to talk about next, was the coordination of records, the medical records, what I think is really unique. So what are you doing there? Why are you doing it? And how is that benefiting the member?
Yeah. So again, going back to solving for Andy.
That's what Mike called this episode, Solving for Andy.
It's called Solving for Andy. So, when I went through my journey through my cancer diagnosis, I was going to multiple different urgent care providers. And it always struck me as odd that I could literally go to two different urgent care on opposite corners of an intersection at two different times, but yet they could not talk to each other. They could not share medical records without me getting involved. And so I always found that odd. And being non-healthcare and not insurance, I started asking questions and started digging in and the whys and everything else. And so it's something that I felt like if I ever did create a solution, that I had to solve that, because to me that was paramount. There had to be a single location where all records lie that happened in my world or in the primary care world. And so if I was in San Francisco for the weekend and I got sick and I went and saw somebody out there, and then the next week I was in Tampa or in New York or in Seattle, and I had to see somebody there, or I talked to somebody on Saturday night because I was coming down with a respiratory illness, I needed to put those in a catalog someplace or an EHR in the doctor's world. And so we created our own. We developed our own technology, our own database that houses everything. So our patient advocacy line, the folks who are the initial interaction with the patient when they call in, literally takes three pieces of information: first name, last name, date of birth. And with those three pieces of information, pops up on the screen, and everything on a single screen from your demographic information, where you live, addresses, company information, plan information that this product is attached to, and how it interacts, and whether we're the front end, the middle, or the back end of the solution. And then dependent information, but more importantly, all of your healthcare records, all of your medical information. And so think about it this way. You're a truck driver, and you start off on the West Coast, and you're driving across I-10 going east. And you've got a doctor out there on the West Coast, but you're getting sick in Missouri, and you need to go see a doctor in Missouri. Wouldn't it be nice if when you made your doctor appointment in Missouri that your medical records followed you?
Absolutely.
So that's what we've been able to accomplish.
So you built a database that houses all that information?
We built a database that houses it. We gather the information, and what's more importantly is within an hour after every consult on telemedicine or virtual care, the file is updated, including all your CPT codes, all your pharmacy information, what prescriptions were made. So everything's there. So like I use a example all the time, that you call in, let's say you have telemedicine, you call in at 2:00 in the morning on Saturday, and you've got an upper respiratory illness, and a doctor prescribes you over the phone a Z-Pack. And Sunday you run out, you grab your Z-Pack. But Tuesday you're still not feeling well. And you call in and you want to go see your doctor. Well, if you went in the traditional fee-for-service world, or most insurance plans today, when you went to go see your doctor, the doctor would have no idea of what happened on Saturday night, because generally those are in a silo, and that medical information is held in a silo. But because ours is not, when you make that appointment on Tuesday, not only in Missouri, but your information is now sent to that attending physician for you.
As long as that physician is in your network.
As long as it's in my network.
Yeah. So
That's correct.
like I always like to understand if there is any caveats. I presume that would be the case. So
Sure.
as long as they're, you said your network is up to maybe 12,000 physicians.
12,000 practicing physicians.
Practice,
Yes.
which is incredible. And that's that scaling. The ability to scale is something that I would like to ask you about. How you guys have been able to do it and solve for it when maybe some of those, I want to say that, what would you say, the brick and mortar style DPC, the geography is always going to be the limiting factor with that. So how have you made this work in a way where you can have 12,000 physicians in 50 states and scale the notion of DPC where others may have had some struggles doing that?
I think to start off, what I like to tell people, and when we sit in front of brokers, and we have, obviously a few national accounts that span multiple geographies, one of the key differentiators that we bring to the table is that the care and the protocols that we practice in Seattle and the price point is the same price point in Seattle as it is in Miami, as it is in New York, as it is in LA. So everywhere across the country, it's the same price point, it's the same protocols that are followed, and our doctors sign up to that, all of our participating doctors. The thing that we insist is that every physician that's in our network is a board certified physician. Okay. And then we do take them through a very extensive credentialing process. And we do quarterly come back and not every doctor re-credential, but we're continuously re-credentialing as we go. Okay. We have the ability to monitor what happens. We look at the quality of the care that's provided. We follow up after every appointment. Our patient advocacy line does. And so we have a very good feel for quality of work, whatever. But it's that ability to be able to provide, like you said, 12,000 physicians all working in unison, all working with the same type of protocols, all delivering the same type of care with unique differences to each practicing physician, because not every doctor went to the same med school. And that applies whether you're in a hybrid direct primary care like I am, or whether you're in a truest direct primary care. Everyone practices a little bit different. That's the challenge that I think the traditional DPC providers have is, some of them, for their membership costs, they cover these items, and other ones charge a little bit more and they cover these other items. And so you have this kind of smorgasbord, and that's where you see the folks who are in the business of aggregating, trying to aggregate the clinics together. But to me, the piece that's missing is that back-end solution, that ability to be able to house that medical information and share that medical information amongst all the providers. Yeah,
and one thing that I like about what you described to me is you're not requiring the physicians to make an either-or decision, right? Like either I leave fee-for-service and go to DPC or not. You offer the ability for somebody to continue to operate in a fee-for-service model, correct, if the geography doesn't support them to go all in, right? But still see people under your model and be paid under the DPC arrangement instead. So how does that work? How do you coordinate that?
Yeah, so I guess let me take a little step back. Yeah. Doctors are not going through the task of and the pain of going through med school to practice in primary care because they're interested in getting rich. Yeah. So generally the people that you find in the primary care setting are truly about trying to help people at the base level. And that's why they choose this and not plastic surgery, for instance, or something like that. They're truly about trying to help people. So their MO, their makeup is a little different than a specialist or a cardiologist or a surgeon or whatever it might be.
Well, I would think philosophically they're more aligned with what I would presume the why a doctor would have to practice medicine is the patient focus.
There's a patient focus. So when you look at that, and let's just, we're in Frisco, Texas today, right? And so Frisco is a suburb of Dallas, and it may have more physicians in it, but you have a lot of towns with one or two doctors in them. Right. And they care for the whole town. So that doc can't just jettison their entire panel. They may have a panel of 5,000 lives, but they can't jettison that panel and end up with 600 because they can't they feel a sense of duty. And so what we do is we partner with that doctor, allow them to continue that and continue servicing that fee-for-service base, but allow them to dip their toe in the direct primary care and allow them to build that side of the practice while still seeing fee-for-service. Mm-hmm. The difference is that we get a VIP slot in our panel, and that's the main difference. So we guarantee 24 to 48 hour turnaround for acute conditions.
I see. Okay.
And so doctors give us a VIP slot. That's the one piece that we do require of any physician, is that they give us that VIP position.
Okay.
And so we get that from the physicians. That's why we're able to do that. And so when you look at it and go, okay, well, how does this compare to PPO network? Well, PPO network, a member is given a very thick document. Now it's on digital copy, right? Mm-hmm. And you're dialing for doctors, and you're trying to find someone that is seeing new patients, 2 that can see you on a timely basis. Good luck. But rarely are you going to be able to find anybody that can see you within 24 to 48 hours, board certified, in an area that you can that's accessible to you as a patient or a member.
Yeah. Well, so then how do we get this where, those doctors are dipping their toes in? Do you reach a point where there might be a critical mass within a practice that's operating in the DPC model versus fee-for-service where they feel confident they might be able to shift? Let's assume there's not one doctor in one location where it's basically impossible to do that. But I'm a doctor that sees the value in this, really likes the DPC arrangement, and maybe I get to a certain 20 or 30% of my population, all of a sudden go, I have confidence maybe perhaps to completely shift. Like, have you seen that happen with some of your physicians?
Absolutely. In the Rio Grande Valley. So when we first started the company in San Antonio, because I was born and raised down in deep South Texas, the first place I wanted to take the concept was deep South Texas. Okay. Because we have a very unique need in South Texas, and actually it's much greater than that now. But people who move from across the border into the U.S. don't have a Social Security number, mm-hmm. and so they can't buy insurance in the U.S., but they can buy direct primary care membership.
Interesting.
So we moved that concept down, and we moved it into Rio Grande Valley, Laredo, and some of my practitioners down there got really busy in the fee-for-service world, and they would get the space next to them and expand their practice and do just a HealthCare2U membership, hire a doc over there to manage that portion of the business. And
they were just operating 2 different practices on 2 different
right next to each
models.
other, in the same building or whatever. I've had several doctors do that. I've also had several doctors partner with us who have their own concierge business.
Oh, okay.
Or who are concierge doctors, who are direct primary care doctors, because it's very challenging for a physician who just to go out there and move out of fee-for-service and move into direct primary care, put a shingle up and say, build it and they will come.
Yeah, come join me now. Yeah.
Now a doctor has to be a business person, go out, recruit patients and all that kind of stuff, and get them to pay that fee for whatever that fee is that they charge.
Interesting. Okay. Well, so let's, I want to go back up in the macro scale in a minute, but I want to go down to the micro scale for a moment. So let's talk, because brokers, you've identified the broker distribution channel as the right path to go down. I think that was very smart. But let's talk about kind of the employer, or who's the right, like, how do you identify a population? If I'm a broker that has 100 clients and I've been thinking about this model, like, what is kind of the appropriate profile of an employer? Who does well in this model? And maybe even tell me who doesn't do well in this model as well.
We're on a mission to partner with the most innovative companies in America to fix health benefits, one plan at a time. NavMD has created a blueprint that delivers world-class benefits to 155 million Americans. Better benefits starts with data intelligence. Our platform is empowering the next generation of advisors to zero in on opportunities to optimize the plan, build the right team, implement proven strategies and solutions. Join us on our journey to revolutionize health benefits. Let NavMD put you a step ahead.
I would like to say there is a cutoff, or there is a cutout that we don't service, but we really we serve every demographic.
Okay.
So I've got a 300-man law firm. I've got one of the largest private CPA firms in the Northeast. as a client. We have
You mentioned a lot of public sector business. It sounds like
public sector is actually starting to come on a lot greater because of the ability for us to talk with stop loss carriers and get them to give us back points from the ag that pays for our services completely and adds additional savings to that employer. So we're getting a lot of headwinds in that particular space. Self-funded, obviously. Fully insured is probably one area. Fully insured in the professional arena, 25-man engineering firm who might have a fully insured product. Probably not a great fit, but very heavy in the service sector. Think about schools, school districts, because direct primary care is membership based. It's not an insurance product. You don't have an enrollment period.
Okay.
It can be added at any time during the enrollment year.
Okay.
So from a broker standpoint, there's it's not just December 31st or January 1 that you can go out there and generate revenue for your firm. You can add this at any time during the year. But more importantly, it's an ability for a broker who's got, let's say you've got a 100-man case and 30 people can afford the health plan. Well, that leaves 70 people with nothing. Add direct primary care for those 70 people. Offer it as a voluntary buy-up, and now you can capture some of that as well, and it provides 85% of what somebody needs in healthcare. People want to go see a doctor. That's what people want, and this gives them the ability to go see a doctor, very inexpensive, and gives them very quick access to see a physician.
Well, so because this doesn't require open enrollment period and doesn't have to be aligned with the actual effective date, even if it does or does not, maybe doesn't matter to this question, but talk to me about the rollout process. Like if I'm an employer thinking about this, or I'm a broker that wants to trust HealthCare2U on behalf of an employer, what do I expect when it comes to launching something like this?
Well, let me step back a second.
Please,
by telling you that, really healthcare, how we've been successful in building the program is we generally start by talking to you about HealthCare2U and the benefits of HealthCare2U. And then we introduce a broker to all the different carriers, or like Pan American Life has us embedded into a MEC, minimally essential coverage. That's really kind of how we cut our teeth coming out of the gate in 2014. Was when the Affordable Care Act came down and people were out there doing these compliance plays with MECs. We added HealthCare2U into a MEC and made the MEC not as horrible as a product as it is. Let's be honest about that. So employers felt better about doing that, and we sold hundreds of those cases. A lot of those restaurants, service sector employees, large populations of employees, but in that service, low income type arena, we literally killed it there. We continue to do a very good job in that, but we've also have sophisticated our offering, I guess is probably the best way to say it, where we've partnered with different distribution partners. We've bundled it with a lot of different products out in the marketplace, whether it be, we've had whole plans created. We do it in health shares, where you combine HealthCare2U inside of a health share, and you're able to do kind of the same thing that we've talked about, where we got an ag discount as a result from the stop loss care. Same applies in health shares because there's a risk associated there too. And we can lower the cost of a health share by embedding direct primary care.
Is this embedded with any TPA services as well?
We have a lot of TPAs creating unique products with us, whether it be indemnity products alongside. So you'll see our product embedded with a host of other products that's delivered out in the marketplace from a host of different vendors. So I think that's one thing when you talk about how did you scale, that's been our creativity, our ability to understand insurance, how to work inside the insurance world. Obviously, it's not my expertise, but I brought in people who understand that world. And then, the price point, being able to cost justify very easily, first year ROI. And then
when you told me this is DPC for the 99%, I think is the term you use. So how have you been able to deliver it at a price point that, your competitors may have difficulty being profitable at? What do you think you guys did differently?
I think everyone's profitable in this space. And I say that because we were profitable in month 3. So
you're saying I should start a DPC
company? When I started, literally when I started the company, I started out of my home office with a single clinic in San Antonio, and we took no outside money. We bootstrapped it ourselves, and we've been profitable at our price point since month 3. And so that tells you that there's profit in this space.
Well, there's so much margin that you can drive.
There's a lot of margin,
yeah.
but I will tell you this, that the doctors, so I'm very proud of this fact, we have a 30-day out clause for every one of our physicians that practices with us. We've never had a single physician in our 9-year history ever part ways with us.
It's impressive.
So I think that speaks for itself. They're happy with what we do. They're happy with our partnership. They're happy with the money they're making on a per patient basis. And the brokers are happy with it because they're capitating a large percent of the claims that normally hit a health plan.
Well, that is why I've looked at this so favorably. Is it nobody's asking anybody to work for free or not make a profit. Like that's never been the ask in our industry when it comes to trying to solve the healthcare crisis. It's just the fairness in the equation, the visibility of the way money flows, and how much a member is going to be charged, and why they're being charged. Those are always the questions that people have difficulty answering in the more opaque arrangement through insurance.
Right.
So that's why I would presume everybody would want to benefit from this, and I think this is how many people are in the equation? 4, a win-win-win-win potentially,
Right.
all around, and that's why I like it so much. So now let's close this thing out and kind of zoom back up, big picture of this. The DPC model is this broad umbrella. How do we get it? Like, where are we in terms of getting it to the point where this is the primary care delivery model in our country?
Well, I think it's, what's probably going to start happening is you're going to probably start seeing a lot of the bigs. You're already seeing it. I mean, you're seeing the Walmarts of the world, the Amazons of the world. They bought, One Medical.
Yes.
Even though One Medical is really a membership / fee for service model, and it's a brick and mortar build. You're starting to see people investing tons of money in that space. CVS, for instance, Walgreens, Village MD, everyone's nibbling. So you're starting to see a lot of other players move into the space. I think the tipping point will be when you start seeing the Blues and, the bigs jumping into space.
And you think that's only maybe a matter of time?
Well, it's difficulty because part of their model is buying primary care practices at a loss generally, because they don't make money in primary care. But what they're after is the disease states, and moving the disease states to the specialists and to all the other facility charges that they can move against that panel. And so, I mean, there's another reason why, for us housing that medical information, it's very, very important. It's also very valuable information.
Of course it is, yeah.
And, we feel like we're very well positioned. We've already scaled. We're already in every state. It's very easy for us to move and aggregate new clinics and new providers.
Yeah.
And, we're kind of that, while we do most of our business with independents, we do somewhat. I mean, I have a hospital who is not only my partner, but their employees are in our plan.
Okay.
So they're receiving the revenue off of it, and also the plan savings off of it as well against their insurance plan.
Well, I think that this seems like a no-brainer for me, but there's obviously problems to solve. Like if it were that easy, we would have already seen this at scale, like completely at scale,
Right.
and everybody would be going through this model. So the future of this, as we evolve and start chipping away at some of those impediments, I think, like you said, maybe the Walmarts of the world are solving for the infrastructure problem to have actual physical locations. But what are some of the other things that you think in the next couple of years, like you need to solve for, the industry needs to solve for to get it at scale?
I think the lab component is a very key component. Obviously, the imaging aspect of it. A lot of your standardized, standalone fee-for-service docs, vacated imaging a long time ago. So that's been kind of consolidated into a lot of your urgent care. And so that's why we have an urgent care component to us as well as a primary care component, so we can offer those different services.
Okay.
And so that piece is, you have to figure that one out. Not everybody can afford those expensive pieces of equipment.
Yeah.
So you have to either build what kind of similar to what I did before in my prior life, where it's a hub and spoke, where you have one location or 3 or 4 locations in a city that act as your hubs, where in the case of Austin, for instance, you have a regional provider there that you go do all your imaging at one location, but then the services are provided outward. So you have a hub and spoke type model.
Yeah.
So I can see where you do some consolidation with scale in that regard. Today, I mean, we're still barely in our infancy. We haven't even begun to scratch the surface of even what we could do in the state of Texas, much less nationally.
Yeah.
And I think that goes, that's the same for everybody in this space. We're still a neophyte in the scope of things of what we could be.
Well, that's exciting.
But I think, I think the growth is there. As a friend of mine told me, when you're dealing with now almost a $4 trillion problem in healthcare, there's a lot of money to go around. Yeah. And there's a lot of money out there to make investments and to make this front end piece, finally solve this front end piece, where everybody, down to a minimum wage, as I mentioned to you before, we're concierge for the 99 percenters. I want somebody making $7.25 an hour to be able to afford to have access to their own doctor and have a doctor looking over their health.
Yeah, I love it, man. Well, so Andy, why don't we do this? We'll wrap it up. Closing thoughts, right? Folks that have listened this far, this has been an incredible conversation. You've enlightened me tremendously. But what do you want people to be thinking about if they've listened this far? Kind of your final thing you want them to leave them with. There's a lot of information we cover, but very useful information.
Yeah, I mean, for the most part, I mean, this is the first podcast I've ever done.
Well, you did a fantastic job.
For the most part, we stayed underneath the radar as we scaled.
Yeah.
And now it's kind of we're starting to do our coming out party. Very few brokers across the U.S. even understand who we are or don't even know who we are.
Yeah.
So certainly go to www.healthc2u.com.
Healthc2U. Okay.
Healthc2u.com. It's healthcare, the number 2 and the letter U. But give us a ring. We'd love to work with you. We've got multiple business development folks out in the field today that are insurance backgrounds and understand the pain of what brokers are going through today and are willing to help. So we look forward.
I love it. And we'll tag everything in the post as well, and obviously get your marketing team a copy of this podcast. But congratulations on your very first podcast, man. It was awesome, and I think you've been in sales long enough that you know how to tell the story of everything, and so I think you'll be very proud of this episode as well. But Andy, I appreciate you making the trip. Thanks for lending your expertise, and hopefully we'll do a round 2 at some point as well.
Great. Thank you very much.
True Captive believes in healthcare that is personal and insurance that isn't complicated. Check them out at truecaptive.com.